Chairman, thank you. Thanks to all of our witnesses and what you bring to the conversation today. It is interesting. In my state, in Oklahoma, we have 4 million people. 2 million of those live in urban areas. 2 million of those live in rural areas. And for our rural hospitals, some consolidation of administrative functions have been beneficial, actually, to have back office somewhere else, and so they can focus on patient care in a very small community. I've also seen some other areas where a management company comes in, takes over a rural hospital, runs it, and then drops it, and it's had major consequences in my state as well. So I've seen both sides of this, and know that we've got to have some oversight in the process on this so that we don't have rural hospitals especially that face consolidation and then just be abandoned at the end of the day as well. Mr. Martin, I want to ask you specifically about some things that may be happening with CMS or with just federal policy that may be encouraging consolidation. Was mentioned before earlier that it is for some procedures, x-rays for instance, some radiology, you get paid more if you're in a larger hospital than if you're independent. So that literally incentivizes moving towards consolidation. So my question to you is, are there things that's happening with CMS or the regulatory environment that's actually incentivizing consolidation in places that it shouldn't be incentivized?
Yeah, thank you for the question, Senator Lankford. I think we've discussed a lot the impacts of site neutrality payments and the facility fees, and it is an incentive for consolidation to take place, particularly between physician services and the hospital institutions, because it is an enhanced payment rate, and that enhanced payment rate is not the only incentive. Many hospitals also have tax advantages that allow them to accumulate revenue that they then can use for mergers and acquisition activities that are not available to other players in the marketplace. But I think there are two things that I would point you to that are a direct competition between physicians and hospitals beyond site neutrality, and one is the simple fact that physician payments traditionally have failed to keep pace with inflation. So physician payment rates are stagnant. Hospitals have access to facility fee payments, but they also have an inflationary update that takes place. And then the second thing is to shift care from one location to another once they've consolidated puts a great strain on rural communities. If they move maternity care to a larger facility, that community and those physicians that provide that services in that community are basically left abandoned in many respects, which drives health disparities and other challenges in rural America.
Are you saying there is something in the CMS structure, the legal structure right now, that's incentivizing that move out of the rural areas into the urban areas for physicians?
Well, with maternity care, there's a number of factors that are contributing to why there's a centralization of that type of care away from rural communities. Yes, there are payment rates and volume rates that are impacting physicians' ability to provide those services in rural communities.
A minority of counties in my state have OBGYN services.
Yeah.
And that's continuing to accelerate. So if I can drill down that a little bit more, you're saying the way that the payment structure is working is actually pushing that towards the urban area out of the rural area. What would you recommend as a fix for that?
So not just payment structures, but also credentialing and privileging structures. So many family physicians and many corporate hospital cannot be privileged, or the hospitals won't privilege them to provide those services in rural areas. They will only privilege individual physicians at larger facilities. So there's a number beyond money. There is a regulatory burden that is preventing access to care in many rural hospitals. And it just goes back to my plea to please address the regulatory and sub-regulatory structure that is preventing physicians and nurses and other clinicians from really being able to provide care in many communities.
Well, I'm a big believer in providing the options because not every rural community is the same, not every urban community is the same. I have a bill that is the Rural Hospital Closure Relief Act. That particular bill extends the ability for it to be a critical access hospital into more places and to give more flexibility into that arbitrary number that was created. I know Senator Grassley has worked on other bills as well to be able to provide for rural health care. Some hospitals do want to have inpatient beds though, and that critical access hospital provides them that option for that. we've got to provide options here, whether it's physician-owned, whether it's critical access, whatever it may be, to be able to provide that flexibility that's needed. And if I can make just one quick comment on this, Dr. Cooper, you had mentioned that it's a possibility that for PBMs and how they're currently structured could have a negative impact on independent pharmacies and rural pharmacies. I would go ahead and say yes. It has a negative effect on rural pharmacies and independent pharmacies. And I can bring you plenty of data in my state and what's happened in the unique coincidence that all the rules change and the fees change and the DIR comes out to a rural independent pharmacy. And then within a week or so, they get a call from one of the big integrated PBM entities and say, wouldn't you like to join us instead? And so I'd say definitely it has that negative impact. Thank you.
I think